use of anticoagulation in patients who have been diagnosed with COVID-19. Dr. Griffith, would you like to expand on that, please?
Sure, I'd be happy to. So initially when COVID started last year, some things have changed over time because now we know more about COVID and the hypercoagulability of our COVID patients. And so initially we were treating patients with D-dimers greater than 3 and putting them on, at least at our institution I practice at, enhanced prophylaxis with enoxaparin 0.5 milligrams per kilogram subcutaneously every 12 hours, or heparin 7,500 units subcutaneous every 8 hours. Over time, the practice at the facilities I cover, any ICU patient now, due to the level of hypoxemia and the increased oxygen requirements, now receives enhanced prophylaxis because they're in the ICU. Mm-hmm. However, at some institutions where I have colleagues, they actually use therapeutic doses. So it may be what your institution has deemed appropriate for these patients. Some of these patients also come in on therapeutic anticoagulation for atrial fibrillation. They've had a DVT or PE in the past, and so maybe they're on a DOAC. And so we would leave the patients on those agents because they actually need them for other disease states. And so it's not, we don't change them to the enhanced prophylaxis dosing or therapeutic dosing with heparin or low molecular weight heparins. We do leave them on that. Now, if the patient ends up going into renal failure or has an acute kidney injury where a DOAC may not be appropriate, then we would switch them over to probably an unfractionated heparin drip.